Good morning and welcome everyone to our webinar, A Gender Lens on COVID-19 and Non-Communicable Diseases or NCDs. My name is Dr. Fanta Waterman. I'm a Managing Director at Surratt Brown Research and Consulting located in the United States, but we're a previous partner of Lake Health and Wellbeing, who is putting on this really fascinating set of talks and comments. So we're really happy that you're here with us today. I wanted to dive right in because we've got a lot of speakers lined up and introduce our first speaker. Just give me a moment to pull up the bio here. And just note that everyone is muted, that this is being recorded. And if you do need to submit any questions, just be sure to include them in the chat or contact a member of our team. So our first speaker today is Dr. Doyin Atewologun. She's an internationally recognized expert on leadership, diversity, intersectionality, and organizational culture. Doyin is a psychologist, a scholar practitioner, a regular media contributor, and multi-award winner for innovative methodologies in promoting inclusion and excellence. She's a dean of the Rhodes Scholarship at Oxford University and also director of Delta Alpha Psi, a niche leadership and inclusion consultancy. Doyin has won numerous awards for excellence in academic publications and was recognized in People Management Magazine's Top 20 Diversity and Inclusion Power List for 2020. We're very, very fortunate to have Dr. Atewologun here to talk about her research and how it relates to this project that she worked on with Lake Health and Wellbeing. And so very excited to introduce Dr. Atewologun. Are you able to load your slides, Doyin?
Yes, I can. Thank you so much. It will mean I stop other screen sharing, so just a flag that I'm about to do that. Good day, everyone. It is such a pleasure to be with you. I'm dialing in from the UK, and I have the pleasure of working with Lake Health to provide an intersectional perspective and lens to the important work that is being done in St Kitts and Nevis with in the aftermath of the pandemic. And what I wanted to do to start the conversation was to introduce perspectives on intersectionality, essentially get us to a point where we have some understanding of what it is, what it means, where it came from, and why it is valuable. And then we will go to the research and the findings and the policy implications. So I'm going to share my screen right now. There is going to be a little bit of participation and involvement. So I just want to give you, kind of flag that it would be lovely for you to use the chat. Go ahead in the chat when I ask, one or two questions. We might even be able to get some voices in the room, depending on how we're doing for time. So I'm just going to kind of start my screen. Start my sharing and really, like we said, talk about the importance of intersectional research. So I don't know yet the extent to which all of us have an understanding of what intersectionality is and what intersectionality means, but I will be hearing or reading from you in due course so that we get a sense of have a shared understanding of it. But before I go into a question of what intersectionality is, I just want to start by thinking about the extent to which we often ask people in work, in healthcare, at school, in many, many, many different facets of our life to self-identify and to categorize themselves based on particular social groups. And so here you have an example taking from the UK, where there is the normative assumption that the assumption that there are two genders, and you ask people to choose whether they're women or men. And then separately, what I have here is one of the many ways in which you can self-identify based on ratio ethnicity in the UK, and here are some categories. This is a demonstration of the way it is in many, many, many processes, many institutions. We are often having to choose between distinct categories, and I, in this example, would pick woman, and on the other panel, I would pick Black African, so the option D. And what intersectionality is it challenges the assumptions that these two things are distinct. And what I would love to do, my first opportunity to get your words, your text in the room, is to say, based on what you think or what you know or your understanding, how would you define intersectionality? And I'm just going to invite you to just put comments in the chat with regards to how you would define intersectionality. And it's absolutely fine if you say, well, actually, not sure. That's why I signed up this morning or today, or for you to guess. We would just love one or two comments. Well, in fact, as many comments as you can in terms of the answer to the question, how would you define intersectionality? So I'm just going to give you a few more moments to just say, when you think about the idea of intersectionality, what comes to your mind? So would love, or if it's easier, put your virtual hand up in Zoom, and Kasia, who's helping us, and also other colleagues will have a look and, get your voices or your words in the room. So I would love to have a couple of responses to the question, how would you define intersectionality, even if it's, oh, not sure, I'm curious, or a word it reminds you of? Anyone?
How did you want us to respond, in the chat or
either by chat or put your virtual hand up, and I'm sure Kasia will. So do you know what I mean when I say put your virtual hand up? So, or you can just go in the chat and say you'd like to speak. Does everyone know what that entails? Should I explain what that means?
I understand, but it probably doesn't.
Sure. So thank you so much, Al, for your contribution. So for people who are maybe not so familiar with how Zoom works, in the bottom right of your screen, you will have a panel that gives you an opportunity to write using your keyboard the answer to the question. I can see lots of, I can see contributions already. So you can put your words, your answers to the questions in there, but you can also go to your name, and you could, I beg your pardon, not your name, you go to the bottom of the screen where the different faces are, the different names are, and there's a reaction button. Kasia, if you please explain, because I'm sharing my screen, I can't really spell out what the steps are. So thank you for what you've put in the text, Kasia. I will leave it to you to add any more instructions, and I'm just going to continue with the questions. So thank you so much, Al, and thank you, Virgil, for the responses that you've given. And thank you for Fanta for your response as well. So when we think about intersectionality, I'm just going to read out some of the responses that we've got. It's about certain factors that are interlinked or overlapped, and they help us think about privilege or disadvantage. Those are really key points. Virgil has talked about the cross-section of sectors in society. And Fanta talks about thinking of all the different aspects that influence a person and their experience in society, which is wonderful. And all of those topics, all of those contributions speak to the idea of what intersectionality is. And this image here is really just to pinpoint the idea of it being multiple different strands of who we are becoming all like coming together to be who we are and how we are located in society. And so what I want to do is I just want to share some more technical definitions of intersectionality and move on to thinking through how it came about, where it came from in the research that I'm familiar with. And when we think about the idea of intersectionality, it means to cross. It's the meeting point of one or of two or more identity dimensions. And what intersectionality helps us to do is to think through the ways in which your experience of one identity dimension actually influences other identities, other categories, other experiences that might be linked to other ways in which you are positioned in society. So right now we are thinking through what intersectionality means, and this image gives you an idea, just one example, that meeting point of race or ethnicity, of class and gender. I've done a lot of work on intersectionality, and what I have here is one of many different definitions, as you heard in my bio, my background is broadly in organizations, organizational psychology. And so I think about the ways in which multiple identities influence people at work. And so one definition that I've used in this, that's published in the Oxford Research Encyclopedia is the idea that intersectionality gives us a way to look at things. It's a critical framework. It helps us understand or organize. It gives us a mindset and a language for thinking through interconnections and interdependencies. So between social identities, social categories, and social systems. So intersectionality is just a useful way to just help us hold in our head the different implications of different identities. It is relevant both for researchers and for practitioners because it helps us be more sophisticated and help us think through some of the more complicated explanations for how the different types of people in one group, like women, might experience work or healthcare differently, depending on women's ethnicities, women's sexual orientations, women's socioeconomic class, women's abilities, disabilities, and other social locations. So it's really helpful for both research and practice to help you think through the different ways in which what you might assume might be all homogeneous, all one way of looking at things, to actually think through what are the different ways in which this group of people's experiences differ. And so with the third paragraph, sensitivity to these differences helps us really understand some of the complexities and nuances of social justice, social injustice, and inequalities in organizations and in other institutions. And from many perspectives, to the degree that we can be more nuanced in our understanding of these issues, we can maximize the chance of social change and policy impact. So this is why this speaks to what intersectionality is, and this speaks to some of the benefits of an intersectional approach. It will be remiss of me to not speak to the source of the term. So Professor Kimberly Crenshaw coined the term intersectionality in the 80s. And while she is a critical legal scholar in the United States, and while she developed the concept, used the word, it is also very important to acknowledge that primarily the experiences of women of color, particularly in the United States, in terms of political activism, has spoken to the idea of intersectionality even before that term was coined. So the idea of thinking through how the relationship between, for example, gender and ethnicity influence gender or ethnicity has long been an issue. But so it's important to acknowledge that. But I also want to acknowledge Professor Crenshaw for coining the term. And what I want to do is very, very quickly, I will oversimplify how Professor Crenshaw coined the term, but to just give you an example of why she thought it was important. So she's a law professor, and more or less she was looking at a case study with an organization. And with this case study, this organization, essentially a group of Black women went to this organization and said, you know what, actually, you're discriminating against us because you're not giving us jobs. And this organization essentially said, no, you cannot claim we're discriminating against you because we employ women and we employ Black people. So you have no case for discrimination. But actually, Professor Crenshaw looked at this case study, and then she said, you know what, when you look at the women that are employed by this organization, all of those women, or the vast majority of the women, were actually white women who were often in receptionist roles. They were like the front face of the organization, and they were there, doing the welcome, and there were white women. And then when you look at the Black people employed by the organization, they were all Black men, and they were all in service roles. They were cleaners, they were like backroom service operators. So yes, the organization employed Black people, but they were all Black men in roles that were deemed appropriate for Black men, or white women in roles that were deemed appropriate for white women. So, but because the woman could only argue based on where the law was, that it was either they were being discriminated against based on gender, but they couldn't argue that because there were white women there, or race, but they couldn't argue that because there were Black men there, their case, their experience was rendered invisible by the law. And so this is a case study that Professor Crenshaw essentially says we all need to pay attention to the intersectional impact of beyond looking at single issues, because otherwise particular people's experiences are rendered invisible. And so I want you to think through your own experiences, intersectionality as lived experience. I would love you to just take a moment. I won't spend too much time on it because we want to kind of keep the pace, but I would love you to just reflect for yourself how your experience, either of work or of being a parent, or your experiences of healthcare, or just generally how others relate to you, and how has that been influenced by your different identities? Because these identities are pertinent. These identities, they give us advantage and disadvantage, like one of the quotes or one of the definitions we heard earlier in the chat. So we all have these different identities, different intersectionalities, and we're going to hear very shortly about how the intersections of gender and having a non-communicable disease status, as well as being a single parent, as well as being less socioeconomic advantage, how all of those interface, and gender, age to some degree, how all of those influence our understanding, and therefore our the impact of our thinking about the solutions and developing policies and other solutions for all types of people. So we'd just love you to just reflect on any experiences and how those different identities might have influenced. So for example, we hear about fathers who are parents who, when they take their children, or if they're single parents, they take their children to school, they feel excluded because usually the school system or the parent support group is all expects potentially a particular age and a particular gender. And so people who might be men or older than the average might actually feel that actually my gender, my age also influence my experience of parenthood as if I'm taking my children to school. One of the stories I sometimes reflect on is how I was walking down the streets of Atlanta recently, and I was walking. So I live in the UK. I grew up in Nigeria, and I live in the UK. And I have a friend who grew up in Nigeria but lives in the US, and we are both, Nigerian women. So we both, people see us as Black women. But one difference between us is I'm Christian and she's Muslim. My Christian identity isn't visible, it's invisible, if I'm walking down the street. Her Muslim identity is visible. She wears a hijab, she wears a scarf. And I remember us walking down the street in Atlanta a few years ago, and someone was giving things out, was giving little candy out, as just, samples on the street. And the person walked past her, like had to go past her to me and gave me the sample, offered me the candy. And like we were both there, we were both next to each other, but this person walked past her and gave it to me. We were side by side. And my only explanation, really, I can't understand no other explanation, is that she's wearing a hijab and so she is invisible. He didn't see her, whatever that means. Or whatever the implications of that are, which are quite significant. So I just want us to think through who is becoming visible or invisible as a result of our policies, our practices, our recommendations, our analyses, as we think through the value that intersectional perspectives and intersectional research can contribute to having more impactful impact on society. And so what I'm going to do now is I just want to talk about intersectionality in specific research, just to give you an illustration. And based on work that I've published around the value of intersectionality in qualitative research, I just want to say a little that actually intersectionalities can be important and pertinent throughout the research process. So for example, before we start research, we can think about our own identities vis-a-vis the identities of the people we are studying. So for example, I can think about whether English is my first language and whether English is the first language of the people that I'm working with, and whether that means I need to think through the assumptions I have when I'm designing my research about how people will understand the questions I'm asking. Just as an example, so one of the things we recommend when we're thinking about the importance of intersectionality in research is having a degree of reflexivity. So for example, just now when you're thinking about your different identities, that sort of thing, and asking, how do my identities affect my study and the participants? And how can I improve my design so that I am not making any assumptions based on my own identities? But the other thing we can do is we can collect data, which we did in this study on the agenda lens on NCDs, that pays attention to multiple identities. So for example, again, the identity web that I just showed you on the slide before, that has been used in research that I've done to help people think through even that question, how has your experience of work been influenced by two or more identities? I've also done research where I've asked people that question, but asked them to keep journals and just at the end of every day to just write how their different identities were influenced, how different experiences influence their multiple identities. And of course, intersectional thinking happens not just in qualitative research, but also in quantitative research. But I'm a qualitative researcher, and the study today is primarily qualitative. So I've focused in on this for this example. And then finally, of course, in your analyses of your data, what are the differences within the categories that you want to understand? And we will be hearing a lot about that very, very shortly when we hear more about the study and the findings. So this is just to emphasize that intersectional thinking can happen throughout the research process. And in the last section of my talk, I just want to give you an example how in my work on leadership, how intersectionality actually helps us look at things slightly differently. And so I just want to give you a little bit of background when we look at research on gender and leadership. Some of you may be familiar with this, but generally speaking, when we look at the research on gender and leadership on women in leadership positions, we have this finding, which we refer to as the double bind that women face when they're in leadership positions. So because of the stereotype, so for this, some of you might be familiar with this, but I just spend a short while just explaining it. Because of the stereotypes that we have in the workplace, women find themselves in this double bind when they're senior positions. Because of the stereotype that leadership or leaders are more like men, women hit this double bind where on one hand, when they're in leadership positions, they are seen as, if you're too feminine, you're seen as, well, you're fitting what you need, as you're fitting our expectations of what women need to be. You're approachable, you're participative, you're caring, you're nurturing, but actually you're a little too tender for leadership. Or if you find a woman in, in a leadership position and she's being authoritative and she's being directive and she's, advocating for where we need to get to, then you find women are being told, oh, no, because they're disrupting the feminine stereotype. Oh, no, you're too tough. You're too tough to be a leader, for us to accept you. So this is a quote from one of the sources. I think it's from the Zeng paper at the bottom right. One woman said, you know what, I can't. This is just hard for me because I can't. I can be edgy. I need to be not edgy, but not without edge. But I can't. I also need to be soft, but not too soft. And this speaks of the double bind. But when you look at the research on gender and leadership, a lot of it does not bear in mind ethnicity. And so what I want to talk to you about is what happens when you put an intersectional perspective on gender and leadership, which is the area that I work in. Because certainly in the West, certainly in countries where Black women and Asian women are underrepresented, so not in the Caribbean islands, but in, for example, Europe and North America, we find that there are stereotypes that are different for Black women and different for Asian women that are in turn different for white women. Such that the stereotypes for Black women are generally that they're seen as aggressive and that they're seen as threatening. And the stereotypes for Asian women is that they're seen as modest and unassuming. So therefore, Black women and Asian women don't face that double bind the way that white women do. So when you're working in organizations and you're mentoring women, one of the things I do when I speak to organizations and my clients is I say, you can't assume that that double bind that I just described to you on the slide before affects all women equally, because actually Black women in the UK, in Europe, as well as in North America, are allowed to be tougher because of the stereotype. And Asian women are, quote unquote, allowed to be soft, modest, and unassuming, such that the feedback not helpful feedback that's given to them is almost like, don't worry, just be gentle for the Asian woman. It's okay. Just say, you know what, it's okay. I don't think you're aspiring for, for senior positions. Or the feedback that's given to Black women is often that, oh gosh, I'm not quite sure that leadership thing, that's a little strong, and I might be afraid to speak to you. Of course, I'm exaggerating somewhat, but the essence of that is the case. And so I'm using this as an example that actually the double bind that influences white women in leadership does not have the same implication for women of different ethnicities. And lastly, I want to talk to you about the teddy bear effect, which interestingly speaks to the research that suggests that because Black men face that aggressive, threatening stereotype, again, in white majority contexts, the research suggests that that a lot of Black men in senior positions have to soften their appearance through glasses, through changing their voices, through, kind of like just being careful and stooping down a little in terms of, just being seen to be a little smaller than they are. This is based on research done by a researcher called Livingston, and he's at Harvard Law School right now. So you might want to Google the teddy bear effect, or his surname Livingston, and he's at Harvard Law School. And so that is also interesting that actually, again, the different assumptions based on ethnicity and leadership influence Black men differently to white women and Asian women and Black women. So this is just to give you some ideas, some insights into how an intersectional perspective is important in research and practice. And I will, the slides will be available afterwards. This is just an example of some of the sources that we've used, as well as some of the further reading if you are interested in. So thank you so much for your participation. I'm just going to pause now and hand back to you, Fanta.
Thank you. That was really so interesting. Just a wonderful commentary. And I can say, as someone who is a Black woman and has led in corporate organizations, I have actually received that feedback verbatim, that people might not like me if I'm too strong, Dr. Atewologun. So I think you were giving the society some grace there, but it certainly does ring true for many of us. Moving along to the project that Dr. Atewologun and Ms. Begho mentioned earlier, I'd like to introduce Ms. AbiBegho, who is an award-winning public health practitioner and the founder of Lake Health and Wellbeing, who is putting on this webinar today and who led and commissioned the research study that will be discussed. It's an NGO that aims to improve the health and well-being of its local, regional, and online community through research, public health interventions, events, campaigns, and offering public health services to small organizations. I'll add a little plug that Lake Health and Wellbeing actually received an honorable mention from the World Health Organization recently, which is a testament to the commitment to the community. Abby started her career in the pharmaceutical industry and has over 15 years experience working in the health sector. She's also very passionate about giving back to her community, and over the years has volunteered and consulted with numerous health organizations in the United Kingdom, the United States, on the continent of Africa, and throughout the Caribbean. Abby holds a Bachelor's of Science in Medical Biochemistry from the University of Birmingham, a Master's of Science in Clinical Biochemistry with Molecular Biology from the University of Surrey, and a Master's in Public Health from King's College. Thank you and welcome to AbiBegho.
So much, Fanta, for the introduction. And thank you so much, Doyin, for that wonderful introduction, setting the scene, helping us understand all about intersectionality. So what I'm going to do is I'm going to talk to you about our intersectional research project based here in St Kitts and Nevis, where we're looking at the impact of COVID-19 pandemic on people that are living with NCDs. And so we're looking at the intersection of a person's identity as an NCD patient, but also gender, but not just gender, their socioeconomic status, personal circumstances, and other factors. So the aim of the project overall was to understand the impact of the pandemic on people living with NCDs and to determine if the pandemic created or exacerbated any gender inequalities amongst people living with NCDs. And then hopefully we feel that the results from our research project would support the development of gender responsive NCD and disaster management policies. So what we did was a qualitative research project. So as I said before, it's an intersectional approach. We're looking at NCDs and gender, but also other factors. And we conducted in-depth interviews with 25 patients living with NCDs. So 19 females, 6 males. And that actually was a limitation of our study, but also it aligned with some of our findings in the sense that males are less likely to want to speak about their condition and less hesitant to seek out help. So although it was a limitation, it kind of aligned with what our findings were in terms of when you put a gender lens on things. We also interviewed 10 policymakers, so policymakers from the government, the private sector, NGOs, and faith-based organizations. But what I'm going to present to you right now is looking at the patient perspective. We do have a separate report that looks at the policymaker perspective. And then once we did all of those interviews, we transcribed them, and then those transcripts were analyzed. So we did a thematic analysis. So I'm going to just go straight into what the findings were. So what we did was we started off by setting the scene. We tried to understand what was the experience, the pre-pandemic experience of people living with NCDs. And so some of the themes that emerged from that analysis was, first of all, patients' perception of the cause of their NCD. And that was particularly important because when you think about someone perceiving what caused their disease, that actually then influences their thoughts around, are they in control of their disease or not? Because if you think the cause of your disease is something that's uncontrollable, then you'll have a different attitude towards your disease. So it was very important to understand the perception of the cause of their NCD. So other themes that came about was the uncertainty of living with an NCD, the factors that exacerbated their NCD, then taking control through self-management, and then the impact of their NCD on their life. And I'm going to walk through each of these themes very quickly. So let's start with the perception. So when we looked at what patients perceived the cause of their illness was, we found there were 4 main causes that people sort of thought about. First was inheritance. So somebody said, look, my grandfather had it, my grandmother had it, my mother's grandmother died from it, my aunt has it, my mother has it, my father had it. So it did not surprise me that they would have gotten this particular condition. Another perception in terms of cause was stress. People felt that stress was the cause of their condition, and somebody here is saying, I think it was the stress that I was under. And then others thought the lifestyle could be the reason for the cause of their NCD, and then others spoke about workplace exposures, which was very interesting. So somebody here is saying, look, I think my hypertension really came about because of my assignment. It was a very difficult assignment that it just broke my health right down. So we can see here, from the point of view of an NCD patient, there are 4 reasons why they think they developed their NCD: inheritance, stress, lifestyle, and workplace exposures. Now, if you're just doing a straight up research project, you might stop here, but of course we're doing an intersectional research project. And so what happens when you put a gender lens on some of these factors? Now, in the interest of time, I'm going to focus specifically on stress. What happens when you put an intersectional lens on stress? When you do that, you then realize that all those who identified stress as a possible cause of their NCD were women. And so you might ask yourself, so what's going on with women in St Kitts and Nevis? Why are they feeling like they're under a lot of stress? And really the take-home message here is that women have multiple roles in society, and those roles are overwhelming if you also add an NCD on top of that. So for example, we have work-related stress. So women talked about tight deadlines and the demands that were placed on them. But you might be thinking, okay, well, men also have work-related stress, but women's work-related stress is compounded or exacerbated by their gender, because women are placed in positions that are more challenging than men. So for example, being the first in a particular position. And this is a good example right here. So this lady said, that's when I developed this hypertension. Maybe it's probably not the best appointment for a woman, maybe. I think I was the first woman. So she was the first woman to hold that position. And so imagine the stress associated with that, and then imagine how that might affect your health and then lead to some type of NCD. So that is a good example of sort of putting an intersectional lens on a particular issue. We then have family-related stress that women experienced. And that came about through the many support and caregiving roles within the family unit, which were demanding and overwhelming. So again, imagine that you have the work-related stress, you have the family-related stress, but then you also have an NCD on top of that. And so here someone was saying, look, the stress level and the pressure on me to always be there for everybody. So imagine you have so many people depending on you, you're also working, and you also have an NCD. So that also adds to the stress. And then what women also said is that they do feel that they worry a lot, and they worry more so than men. And so one woman here was saying, look, I'm a worrier in terms of always worrying about everybody. I have to worry about everybody and if everybody's okay and how things are going, and it's constant. So women are worrying, they have work-related stress, they have family-related stress, and they may also be at increased risk of developing an NCD. So what we found though was that men tended to have a more relaxed approach to their NCD and also to life in general. But that could be because it could be that men are internalizing their concerns. So they might be stressed, but we don't know it because they're internalizing those concerns. And so one male NCD patient said to us, I'm a cool going person. If you look at me, you might say it doesn't look like anything really bothers me. So you can see, very relaxed, but maybe on the inside, something might be going on. There might be some stress there. So what is the implication of this? The implication of this is that it suggests that women with NCDs are more exposed to stress than their male counterparts. And this could put women with NCDs at risk of their disease worsening. And then what is the pandemic implication of that? So this could then mean, or we could ask ourselves the question, did the pandemic create an extra gender-specific stress-related burden for women living with NCDs? And the short answer to that is yes, it did. And I'll talk about that a bit later on. So continuing with the intersectional sort of approach, we now then look at other factors, some compounding factors when we look at women, NCDs and stress. So one of the things that we found was that age was a compounding factor. So our project suggests that women or younger women are exposed to higher levels of stress. And that's because, it's the stage of life. They're working, they're looking after children, they play all these multiple roles in society. Whilst older women, they're retired, they have a more relaxed kind of life. So age was a significant compounding factor. Income. So women on a low income seem to be more exposed to stress, and that's due to the many financial challenges they encounter. And you have to remember there are also financial challenges associated with managing your NCD. So that is all the healthcare costs. And then of course, personal circumstances. So you have single mothers who are under a lot more stress. Maybe somebody might be living in a home that is very stressful as well. So these three factors also compounded the stress that women were undergoing. So what is the implication of that? So the implication of that is that single mothers living with an NCD who are on a low income are likely to be the most vulnerable with regards to exposure to stress. And therefore, they are more at risk of their NCD exacerbating, but they were also more vulnerable going into the pandemic. And the thing is, you might miss this fact if we only just take a very one-dimensional look at NCDs. So this allowed us to identify a very vulnerable population within the NCD population. So I'm now going to look at three things together. So I'm still thinking about the pre-pandemic experience of people living with an NCD. So what people raised was there's a lot of uncertainty living with an NCD. They also talked about the factors that exacerbated their NCD and then taking control through self-management. So I'm going to kind of look at these together. So in terms of the uncertainty of living with an NCD, what people said was that living with an NCD is very unpredictable. Their health can change hour to hour, day to day. And the downside of that is that people don't understand that. So you might be healthy 1 second or look healthy and feel healthy 1 second. And then maybe half an hour later, you feel very unwell. And people on the outside looking in maybe don't appreciate just how unpredictable an NCD is. Many ups and downs with an NCD, and people's health can deteriorate very quickly. One person described their NCD as a silent killer. So this was the concept of their NCD worsening without them even realizing it. And here was a good example. So here we have someone saying, you know what, you don't even realize that you have hypertension. I don't suffer any headaches or anything else like that. And the first time I realized it probably affected me was when I had a stroke. Now that stroke could have been life-threatening, but luckily it was a mild stroke. But you can see though, how the unpredictability and that concept of the silent killer. Another thing that was raised in our study was the factors that exacerbate NCD symptoms. So what makes NCD symptoms worse? And two key factors came up, and that was stress. Stress tended to make NCD symptoms worse. And like we mentioned before, if we put a gender lens on that, we're seeing that women with NCDs are more likely to be exposed to stress. Hence why I said in the previous slide that exposure to stress means that women are at increased risk of their NCD getting worse because they are more likely to be exposed to stress. Also, environmental factors came up as factors that might exacerbate an NCD. So things like exposure to dust, sunlight, volcanic ash, smoke, chlorine. And you wouldn't believe it, but yes, there is a gender component to this as well. And that is because men and women may have different exposures. So we have men who were in our study who were doing very physical or manual roles, and they were more likely to be exposed to dust and smoke. And that means that they're more likely to have an exacerbation of respiratory related NCDs. For women, for example, lupus is more common in women, and sunlight tends to aggravate a lupus. So you can see that there can be a gender component to environmental factors that may not necessarily be immediately obvious. So the next thing that came up was, okay, I have all this uncertainty. My NCD symptoms can be exacerbated by stress and environmental factors. But what can I do? And what we found was that people were trying to take control of their NCD through Ncd self-management. So Ncd self-management techniques included things like healthy diet, physical activity, trying to get a lot of rest, maintaining a healthy weight, building some coping skills and building resilience, and taking part in regular monitoring and checkups of their NCD. So what we found with the pandemic was that the pandemic was a disruptor for some people living with NCDs, and it exacerbated the uncertainty they already felt coming into the pandemic. Now, the increased uncertainty and the policies to control the pandemic affected people's ability to control their NCD, and therefore, this made people living with NCDs more vulnerable as we went into the pandemic. Also, those living with an uncontrolled NCD, so maybe those that might have had really high blood pressure that wasn't controlled or their diabetes wasn't under control, they were even more vulnerable, particularly during the 24-hour curfew periods. So going back to the different types of NCD self-management techniques, what I want to do is kind of walk through a couple of these NCD self-management techniques and then explore the gender component to some of these and how the pandemic impacted these. So when we look at the NCD self-management technique of healthy eating, first of all, the general consensus was that for some, their focus shifted to ensuring that they had enough food to eat during the pandemic, rather than focusing on healthy eating. So, which was the main concern before the pandemic. So before the pandemic, people were concerned about healthy eating. As the pandemic then came into force, people were now more concerned about, look, do I even just have enough food to eat? So that was quite a big concern. Apart from that, some of the main issues that arose with people living with NCDs was, first of all, food affordability. So before the pandemic, food was generally affordable. Some healthy food was expensive. But after the pandemic, the cost of food increased quite significantly, and the cost of healthy eating increased quite significantly. So that impacted people's ability to participate in healthy eating as a way of managing their NCD. The second issue that arose was access to food, like physically accessing food. So the restrictions, the long lines at the supermarket, all of those factors made it very difficult for people living with NCDs to really access food and access the type of food that they needed. The other issue that came up was improvements and worsening of their diets. So you had people's diets that improved, and the reason for that was that they were no longer buying those treat items. They were no longer buying the ice cream and the cakes. So their diet did improve during the pandemic, and that actually then helped their NCD. But then you also had other people whose diets worsened during the pandemic. And that was because of the food affordability issues and the food access issues. And that, of course, had a negative impact on their NCD. And then we had evidence of emotional eating. So people were eating because of stress or eating because of boredom. You know, they're locked down, they have nothing better to do, so they're eating. And this emotional eating tended to be people eating unhealthy food, which obviously would be have a negative impact on their NCD. So now what happens when we put a gender lens on these issues around food? So what we found was single mothers on a low income were most vulnerable. The pandemic worsened food affordability for them, and this was because of job losses, reduction in work hours, increase in food prices, and then having to provide additional food for children who are spending more time at home. The other issue that came up was that single women on a low income, they're single, they're on their own, so therefore they had to shoulder the burden of the long lines at the supermarket. And doing this whilst having an NCD was more challenging than the average person who's absolutely fine. And a good example here is a young lady who said to us, sometimes, during the pandemic, you go to the shop and you have to stand up in a long line, knowing that sometimes you don't feel good and you have to be in a line. I had to go myself. I prayed when I wasn't feeling good. And I think the part of that quote that made me feel a little sad was the part that said I had to go myself. There was nobody else to help her. There was nobody else to support her. She physically had to go herself, or she and her family members would not eat. So there is a gender lens for you. So men seem to be shielded from these issues. So men tended to have somebody else that was cooking for them, shopping for them. So they didn't really have these types of issues that, say, a single mother would have. Also, what we found was that older women with NCDs were shielded from these issues as well. So, they had family and friends that shopped on their behalf. There was a senior citizens line, which was very beneficial. So that helped them get in and out of the supermarket fairly quickly. But what we found was that there was a slight gap for older women who are partially dependent on family and friends. So these were older women who maybe 3 or 4 days a week, they had somebody looking after them, providing food, cooking for them, bringing food, maybe 3 or 4 days of the week. But then what would happen the other days of the week? And this is what one older participant said. So she said, the only problem with that is sometimes was a meal. There were the odd days that I didn't feel I wanted to do any cooking, sometimes something like that. Then on Sundays particularly, it kind of worried me for a bit. So she was very worried because there was Sundays and other days where basically she might not feel like cooking, she might not have been feeling well, but there was nobody to bring her food on those days. So that really worried her and created some anxiety. So now when we look at emotional eating and we put a gender lens on that, what we found was that women were more likely to turn to food to manage stress, and it appeared that men were more likely to turn to alcohol to manage their stress. Both of these things, very negative for managing an NCD. So if we now turn to exercise, another self-management technique, what we found were 3 things. Some people, there was an increase in the amount of exercise during the pandemic. Others, there was a reduction in the amount of exercise. And then we also saw some inequality. But to be honest, we're seeing inequality with every single factor, but I've just highlighted it here. So looking at the increase in the amount of exercise, what we found was that the pandemic-related restrictions created time for people to exercise at home. But the key factor here, though, was that you had to have the space at home to exercise or the income to purchase equipment if you didn't have space at home. And somebody here was really highlighting how lucky they were because of their circumstances. So this person was saying, look, I was really lucky because I had the space. So when we were in lockdown, I could go out onto my veranda and I could go down into the garden. So this person had the space to exercise. And during the pandemic, for people living with NCDs, online and TV-based exercise became very important. But then you have the converse of that. You have people where there was a reduction in the amount of exercise that they were able to do. And that was due to either a lack of space or just they lost motivation because of the pandemic. They were just anxious, they lost motivation. Now, this I find as a very strong kind of quote from a participant explaining that she didn't have the space to exercise and how that made her feel and how she was then worried about her NCD. So what this participant said was, I would strongly desire the chance to go for a walk. So most mornings I would go to the gate, looked out as though I was a prisoner for as long as possible. After a while, feeling somewhat defeated, I would come back inside. Then I was concerned that the stresses from the pandemic, along with the lack of exercise, would cause spikes that maybe medications couldn't control. So that would then cause me to worry about my blood pressure altogether. So now you can see the contrast between two people. We have somebody who doesn't have the space, felt like she was a prisoner, but also was then worried that all the stress and all of that fact that she wasn't able to exercise would then exacerbate her high blood pressure. Then looking at the inequality, and I guess I've highlighted it, those persons that were able to exercise basically tended to be persons on a higher income because they had the means, they had the time, and they had the opportunity to exercise. And that actually inequality is a general inequality across all the different factors. Those persons on a high income basically were able to practice self-management more so than those on a low income. So looking at gender and exercise during the pandemic, what we found was that overall, women benefited during the pandemic when it came to exercise because they had more time to exercise, because they were given a bit of a break from the multiple roles that they play in society. So having that break meant that they had more time to exercise. But again, single mothers on a low income were at a disadvantage. They were working from home while caring for children, assisting with homeschooling. So they had a very busy home environment during the pandemic, which meant that they didn't have the time to exercise like others did. When we looked at men, we had men in our research project who actually did a lot of physical and manual labor, and they actually used that as a means of exercise. But because of the pandemic, they weren't able to go out to work. And so therefore they weren't as active as they were before the pandemic. So this was a disadvantage for men in the sense that they weren't able to participate in their normal physical activity because their physical activity was physical activity related to their jobs. So medication is another self-management technique. So if we look at medication, it was an interesting one. So prior to the pandemic, NCD patients were already in the habit of ensuring they had ample supply of medication. So with the onset of the pandemic, most participants were even more vigilant about stocking up on their medication, and doctors and healthcare centers, pharmacies were very accommodating and facilitated this. The most challenging periods with regards to the pandemic and medication management were the 24-hour lockdown periods. So, but the thing is, participants were pretty much prepared. So this vulnerability was mitigated on overall. But there was one person within our population who ran out of medication during the 24-hour lockdown period, and this did have a negative impact on their NCD. So outside of the 24-hour lockdown periods, what we did find though was that the curfews, the early closure of pharmacies, the physical distancing that created the long lines, eventually this created problems with medication management, and then started seeing as time progressed, more people with NCDs running out of medication. So this did actually become a problem in the long run. Older persons had assistance from family members, and senior citizens' lines were also very helpful. So they tended to be shielded from this. But one thing to say is that medication did become a lifeline for most people living with NCDs, as it was one of the only things that they felt that they could control during the pandemic. So they were very particular about their medication and making sure that they really had enough. So some other issues that came up during the pandemic with regards to medication management for NCD patients was that, you know, the pandemic disrupted people's daily routine. So you had a patient where before the pandemic, they had a very structured routine. You know, I wake up at this time, I take my medication at this time, I have my breakfast at this time, very, very structured before the pandemic. But the pandemic completely disrupted that. And this then led to disruptions of medication management. So where people were now like forgetting to take medication, or I should say one person forgetting to take medication. So that completely disrupted their NCD and then led to a little bit of deterioration. In terms of another issue, one participant had medication resistance, which arose during the pandemic. So this is where the medication is no longer working. And she found, look, her disease was seemed to be getting worse and worse, and she couldn't figure out why it was. And what it was, when she eventually got to the doctor, it was that her medication was no longer effective, but there was a huge delay in her identifying that. So again, the pandemic caused a delay in identifying a very important health issue. Those on a low income we found were at a risk of running out of medication as they couldn't afford to buy medications in bulk. So that was sort of an income disparity there. And then when we put a gender lens on it, again, single mothers on a low income were more at risk of having issues with accessing medication. And then finally, when we look at men and medication, prior to the pandemic, men were already hesitant to take medication. They had concerns over side effects, over the health impact of being on long-term medication. And what happened was the pandemic created additional barriers to accessing medication. So again, these are some of the gender-related issues around medication management. Now, thinking about rest was an important Ncd self-management technique. And during the pandemic, the slowing down of society provided some participants with the opportunity to rest, and this benefited their Ncd. So some participants used the 24-hour lockdown period to practice some self-care. Some made use of the time to rest and recuperate. Those able to do this were those actually whose employment wasn't significantly affected. So they had some peace of mind about the future. So what we found was those persons whose jobs were very secure, they were actually able to use the pandemic as an opportunity to just rest, recuperate, and on all of that. But what we found though, was that others were not able to rest. So we had others that were consumed with the anxiety of the pandemic and its impact on their lives and livelihoods. And those people were not able to use the pandemic as an opportunity to just rest and recuperate. And then for some, the pandemic brought extra caregiving roles and responsibilities. So they definitely couldn't rest, regardless of if they had the time. They couldn't rest because either now they're looking after an older family member or they're looking after their children who were at home for longer periods of time. So some just really couldn't rest at all. And then some participants, their personal circumstances at home, whether there's tension in the home environment, that made it very difficult for them to rest. So again, if we put a gender lens on this, the poor single mothers on a low income, again, were at a disadvantage and not able to get a rest. But also grandmothers caring for their grandchildren were at a disadvantage because they now had this additional caregiving role, which made it hard for them to rest. And then we found that male essential workers living with an NCD involved in sort of very manual or physical jobs during the pandemic had significant demands on them. So they were being called out to long hours during the pandemic. So while everybody else is resting, they're out there in the field, and this disrupted their ability to rest. So again, this points to the fact that we also need to take care of our essential workers who are living with an NCD. So weight management. So the pandemic affected some NCD patients' weight. Some lost weight, which benefited their NCD. Some gained weight, which exacerbated their NCD. And so this is just a quote from one person. So this person said, look, staying at home all day makes you eat. Not being able to hit the streets makes you eat. So I gained weight. Not a good thing, but it is what it is, kind of thing. So that's the issue with weight. Now, what we found was that when you put a gender lens on this, weight management appeared to be more of a concern for women. All those who raised issues around weight were women. So therefore, the pandemic and weight issues primarily affected women. So if we're thinking about interventions to target sort of NCD and weight management, it may be that we need to focus more on women. So monitoring and regular checkups, which is another important aspect of NCD self-management. So here, what happened during the pandemic was that several people living with NCDs tried to maintain contact with their doctor during the pandemic so they could monitor their NCD. Now, some doctors were very proactive. They made themselves readily available. Others were not. The 24-hour lockdown period, though, created a lot of anxiety for patients because obviously it was harder to access their doctors. So here we have a patient here saying, look, during the sort of lockdown period, I created scenarios. Well, if it got really high, that's her blood pressure, I couldn't access the care that I would want to have because my doctor is on lockdown as well. So that created a lot of anxiety, thinking about what would happen if I had a medical emergency during the 24-hour lockdown. My doctor's on lockdown, how would I reach out to him? So that created a lot of anxiety. So now there were patients who before the pandemic didn't have a doctor or who did not visit their doctor regularly. Now these patients would have benefited from being under a doctor's care during the pandemic. And this is because the pandemic exacerbated their condition. They had medical challenges during the pandemic, and they needed sort of medicines to be adjusted. But because they didn't have a doctor, they didn't visit their doctor regularly, they didn't really have a doctor that they could call on during the pandemic when they had an issue. So this meant that they were left unsupported. So another issue we had was participants who needed specialist care that's not available in St Kitts and Nevis. They were not able to now travel to access that care because of border closures. And then finally, I guess something positive is that participants who attended the diabetes and hypertension clinic before the pandemic, they continued to regularly attend those clinics, and they tended to be those persons that were doing better and those persons that had their condition under control because they had the support of the clinic. So the clinic itself provided a good source of information of COVID-19 and a good source of information on how they could stay safe and healthy during the pandemic. So now, if we put gender lens on regular monitoring during the pandemic, what we find is that the pandemic created an additional help-seeking barrier for men. And as I mentioned before, men were already hesitant before the pandemic to visit their doctor. So the pandemic just created this additional barrier. So men were less likely to kind of reach out to their doctor during the pandemic. For women, the issue that we found was that there's some specialist care that women do need because of their increased risk of developing some hormonal conditions. So we're thinking of things like PCOS, fibroids, endometriosis, some other conditions like lupus. And they didn't have the support that they necessarily needed during the pandemic, particularly during the 24-hour lockdown periods. So they were more likely to not have support and medical care during the pandemic because of the border closures and lack of expertise on island. So I'm coming towards the end, so I'm just going to touch on the impact of NCDs. So before the pandemic, people basically said to us during this research project that their NCD affected every aspect of their life. It affected their physical health, their mental health, their relationships, their social connections, their work, their finances, their daily activities. And in the report, we go through exactly how how an NCD affects all these different aspects of a person's life. So what I'm going to do is just touch on two of these aspects, just to give you a flavor of what the pandemic then did to the impact of their NCD. So when we look at mental health, how the pandemic impacted the mental health of people living with NCDs, what we saw was that pandemic exacerbated the stress and anxiety of living with an NCD. Now, some of the pandemic-related factors that negatively affected the mental health of people living with the NCDs were things like the people thinking about the increased risk of developing COVID-19 and developing severe COVID because they have an underlying health issue. People were concerned about the stress of the pandemic exacerbating their symptoms. People were worried about job losses, various different things, loneliness, sadness and depression, concern about family members. So there were many different things that were concerning people living with NCDs that negatively affected their mental health and exacerbated their mental health issues. But there was some positive in terms of mental health. So there were some pandemic-related factors that positively affected the mental health of people living with NCDs. So that slowing down of society gave some people living with NCDs the opportunity to rest, to spend time with family, to explore new hobbies, and to just recuperate from the mental toll of their busy schedules. So now if we put a gender lens on sort of the mental health aspect, what we found was that the source of mental health issues or mental health concerns or just things that were worrying men were very different to what was worrying women. So for men, there was the pressure of being the breadwinner that was amplified. You know, the pandemic created extra anxiety due to the reduction in their income created by business and border closures. For women, women were worrying about lots of different things. So, you know, there was extra caregiving roles. So there were some women that had to look after elderly parents, and this created anxiety. Some women had more childcare responsibilities. Women were very concerned about their children throughout the pandemic. They were worried about their health, their well-being. And then women tended to be the ones that were shouldering a lot of the burden of challenging circumstances that arose during the pandemic. So for example, you know, if there was a death in the family, if there was a sickness in the family, women tended to be the ones that had to deal with those issues. And of course, that increased their anxiety levels. But there were other women who were able to use the pandemic as a moment of relaxation and those tended to be women on a high income. So they were able to relax, recuperate, and that improved their mental health. So if we look at physical health, how the pandemic impacted people living with NCD's physical health, some participants reported that the stress of the pandemic triggered physical symptoms, some of which they had never experienced before. So for example, an asthma attack, some participant might have had asthma that was very controlled, and then during the pandemic suddenly developed an asthma attack, acne, someone had a mild stroke, exacerbation of hypertension. So these are just some of the physical manifestations of the stress related to the pandemic that affected people's physical health. Others explained, and I've mentioned it before, that lifestyle changes, not being able to eat that healthy food, not being able to exercise, that exacerbated or alleviated their NCD symptoms, depending on what that lifestyle change was. So when we look at gender and physical health, some issues that arose during the pandemic, particularly during the 24-hour lockdown, tended to affect women. So what we found was that chronic gynecological conditions causing severe pelvic pain, those kind of things were occurring during the 24-hour lockdown, and women weren't able to get support for that. Debilitating physical symptoms related to like lupus, again, not being able to necessarily get the support that you need when you're having those types of medical challenges during the lockdown. And that seemed but to affect women quite significantly. So those are some of the issues. Okay, so coming to the end now. So really just to sum up by saying what our research showed is that during disasters, we have particular groups of people living with NCDs that require more attention. So I'm just going to outline who those are. So firstly, people with rarer NCDs or NCDs that do not fall under local, national, and regional priorities need more attention during disasters. And the reason for that is that their condition doesn't get enough attention, and therefore there is a lack of support. Single, retired, older women also need more attention during disasters because they're at risk of isolation and loneliness. NCD patients on a low income are also in need of support during disasters. And this is interesting because what we found was that NCD patients on a low income tended to have just a high enough income where they weren't eligible for certain types of support. So they tended to not get the support that they needed because their income was just a smidgen high enough for them to fall outside of that sort of bracket where they would have been eligible for support. So they weren't receiving the support that they needed during the pandemic. So single mothers on a low income, again, as I mentioned throughout this presentation, are definitely in need of support during disasters. They're managing their NCD while balancing several roles and responsibilities with sometimes little or no practical, emotional, or financial support. Men in general need a bit more attention because they're hesitant to seek out help and therefore at risk of not receiving the support and medical attention they need. And then women affected by chronic reproductive health issues and other conditions where women are more at risk, they are in need of support too because there's a lack of specialist care and support. So we do need to pay attention to that. So in summary, so just really, this is a schematic just to summarize everything. So what we have is that people living with NCDs before the pandemic, their NCD impacted every aspect of their life. Now, one of the ways that they tried to mitigate the impact of the NCD on their life was that they employed various Ncd self-management practices. Now, the pandemic was a disrupting factor. It amplified the impact of the NCD on people's lives, and it also disrupted people's ability to control their NCD through Ncd self-management techniques. But in some cases, the pandemic actually facilitated and enabled people to practice good Ncd self-management. So that, for example, the slowing down of society allowed people to exercise. So what we are finding is that the factors that are affecting patients' experience of living with an NCD, factors that affect people's ability to self-manage, and people's experiences of the pandemic were dependent on their gender, their age, their type of NCD, their socioeconomic status, and their access to support. So I hope that kind of summarizes everything in one slide. And then just to conclude, so the pandemic was a disruptor for some people living with NCDs. It created even more uncertainty and exacerbated the challenges faced by people living with NCDs. The increased risk that people with NCDs faced when it came to COVID-19 compounded their anxiety about their health and future. What we found was that the COVID-19 policies and protocols that were introduced did offer some protection from COVID-19, but in some cases, these protocols and policies affected patients' ability to engage in successful Ncd self-management techniques, and this resulted in worsening of symptoms. So if all the policies around restricting movement and all of those types of things, that did have a negative impact on people's ability to self-manage. So men and women living with NCDs have a variety of different needs. Therefore, we need policies and interventions that meaningfully take gender into account, especially during disasters. And also, gender-related inequities existed amongst people living with NCDs before the pandemic. Although they might have been unidentified, they did exist, and they were exacerbated by the pandemic, particularly for single mothers on a low income. So our recommendation overall is that when we look at the disaster management process, which you might be familiar with, the disaster management process involves 4 stages: response, recovery, mitigation, preparedness, and there you have the disaster. Our recommendation is that within the disaster management process, we need to embed NCDs into that process. And one of the ways that we can do that is that we need to consult with people that are living with NCDs. We need meaningful involvement of people living with NCDs as we develop, plan, and monitor disaster management strategies. So we've developed this little framework here, which we can send to you, where what we've done is that we've looked at each of the stages of the disaster management process. And when you click here, we are giving you some guidance on how you can embed NCDs and gender into each of the stages of the disaster management process. So obviously we can send this to you after this session so that you can have a look at that. But one of the key things is, as we're thinking about embedding people living with NCDs in the disaster management process, we have to think about the values and ethos of that response. People are living with NCDs. It is a challenging disease to deal with, or challenging set of diseases to deal with. So when we're thinking about disaster management, and when we're thinking about NCD policies in general, these policies need to be developed with empathy in mind, sympathy, kindness, equality and inclusion. We need to be thinking about a human rights-based approach, and of course, it needs to be gender sensitive. So that is really our sort of general recommendation, and we have some very specific recommendations on how we can support people living with NCDs during these sort of challenging times. So that, in a nutshell, is it. So I would just like to say some thank yous. So I would just like to say thank you to all the people that took part in this project, all the NCD patients that allowed us to interview them, all the policymakers as well that allowed us to interview them and gave us some really good insight, the Commonwealth Foundation who funded this project, of course, Dr. Doyin Atewologun, thank you so much for your research advice and input, very much appreciated. Iselin Phillip was our research officer. AbiBegho designed the digital framework that you just saw, but also our research reports. Sherry Ann Weaver was our intern. Shade Douglas was a very fantastic and detailed transcriber of all the interviews. Roma Richardson was our editor for the reports. Also like to thank the Ministry of Health for facilitating and really helping us identify NCD patients. And of course, ZIZ and WinFM for putting out some ads for us to help us recruit NCD patients. So that's, in a nutshell, what were our findings from our COVID-19 NCD project. So thank you so much for your time, and I hope you found that useful.
Thank you, Abby. That was very, very informative. You've told me about that project a couple of times, and you said that there was quite a bit to discuss. So just so much there, and I'm glad that you're able to make some of this information available after the webinar. So far we've heard from Dr. Atewologun about intersectionality and sort of how it presents itself, how it manifests in patients. And then Abby took us through this project in particular and how intersectionality gets demonstrated and how patients go about taking care of themselves and their loved ones, and sort of how they interpret how their environment is helping them. What I wanted to do first before we broke into the Q&A is hear from Drs. Pierre, who's Vice President of the St. Kitts and St. Nevis Medical and Dental Association, who was speaking a little bit earlier, as well as Mr. Virgil Jeffers, who's Executive Director of the St. Kitts Department, of Gender Affairs. We've heard a lot about intersectionality and about research done specifically in the St. Kitts and Nevis population. So would just like to open the floor up to them. Perhaps you can go first, Dr. Pierre, and tell us sort of what initial feedback you have based on what you've learned so far.
Hi. So, I mean, very, very fascinating information. As I mentioned earlier when we spoke just before the session started, I spoke to the fact that as a medical doctor, you have your hands really deep into these sort of situations, but you never really look at it from that sort of statistical standpoint and all the factors that we've discussed here and how they've played into this. And it really is fascinating. I mean, the thing about chronic non-communicable diseases is that it develops over time. So one of my fears is that I think we're really just at the initial stages of seeing what the impact of this is going to be for individuals who already have pre-existing conditions, but individuals who already had vulnerabilities like obesity, for example, and who may already begin, be going through the stages until they're actually diagnosed with a particular disease. During the pandemic, one of the interesting and perhaps most important distinctions that I found was made in reporting on COVID-19 deaths was deaths that actually resulted from COVID-19 infection and deaths that were related to COVID-19. And while that wasn't done in St. Kitts and Nevis, in St. Lucia, for example, that distinction was made. In essence, someone may have a COVID-19 infection, but the cause of death is not necessarily COVID-19, but certain vulnerabilities that exist. And I think for me, what that did was sort of shed light on how those chronic non-communicable diseases and all of what we've discussed, how that would have actually predisposed someone to not only contracting an infection, but suffer a severe form of the disease to the extent that they would actually lose their life. Here in St. Kitts, for example, during the pandemic, one of the challenges we faced, and unfortunately we failed to overcome as the Medical and Dental Association, was to have the government consider private doctors' clinics as an essential service that needed to remain open, right? So essentially, when supermarkets were open, private doctors weren't given the go-ahead to open their offices. So the patients who were afraid of and felt that the hospital represented a real and present risk of infection for them did not go to the hospital. So if you had hypertension or if you were out of your medication and you couldn't get to your doctor, you remained without it because you felt that and then all the information that existed at the time was that those individuals were the ones who were most vulnerable and more likely to die from infection. So that fear and concern of actually contracting the disease prevented individuals from accessing care, right? Not to mention, of course, the hospital being as is, so much of the resources were moved towards caring for COVID-19 patients. So you had outpatient clinics, for example, was stopped, right? You had surgeries being stopped for elective surgeries being stopped. So a lot of that care being diverted to COVID-19 really, did have a detrimental impact on individuals who were suffering with chronic non-communicable diseases. In fact, and Abby spoke of individuals with lupus. Well, the reality is that of the 13% or so of the world population with autoimmune diseases, 73% are women, right? So that speaks to the individuals, just some of the vulnerabilities of individuals with autoimmune diseases, and how women were actually perhaps most affected in that regard. Obesity as well, right? There's also a slight lean, heavy in terms of the ratio of women who are obese, right? So those are some of the things as well. And in some settings, individuals living with HIV and AIDS as well, there's also in some settings a predominance of women. So imagine individuals like this who weren't able to, get adequate exercise. At Ross University, where I worked, the majority of our domestic assistants who actually part of their job actually lends itself to some form of exercise were home, right? They were home, they were getting paid. Yes, I think we did a great thing as an organization, but these individuals no longer had access to the exercise. So when you saw them after the period of lockdown, they had gained 15 and 20 pounds, right? So that in itself, and we saw a number of them, that blood pressure trending upwards. Some individuals who were uncontrolled, individuals who decompensated right over time, individuals who were once hypertensive are now having heart failure. And some of the things I think that would have factored into this, increasing domestic abuse, right? There are a number of individuals women who were at home with a spouse who was now home, and just the frustration from job loss, from not having to remain in a home environment for such an extended period, being cut off from some of the social circles. You saw that domestic abuse and what that did in terms of some of the decisions that were taken around compliance with medications, right? Individuals who decided to seek care, the women who actually felt hopeless in the process. And as a result, just felt that, they just left everything to God, as they would say here in St. Kitts, right? And because they were, stress, depression set in, and individuals just made some of the choices that were less healthy at the time. As well, individuals, pharmacies have been closed, and that's of decompensation of certain illnesses, because individuals did not have access to medication as they would have had. Childcare responsibility, which we spoke about, the majority of that fell squarely on women. Many women had to juggle being at home, having to learn to work in a remote environment for the first time, not having the right setup in the home environment, but being expected to deliver just as if they were in the office while juggling childcare, and what that did for the rates of chronic stress, and how that also played into some of the trends that we saw for this chronic non-communicable disease. The other thing was economic hardship, right? And how that shifted the balance of power in the direction of men. So, a number of individuals who I saw during that time, you saw an increase in STI, infections, right? You saw individuals, for example, who felt that they may have contracted HIV and AIDS because they lost the ability to negotiate what sexual contact would look like. Individuals who became pregnant, unwanted pregnancies, and as doctors, we speak of pregnancy as a stress test, right? If there's certain vulnerabilities, pregnancy exploits that, right? If you will be hypertensive in 10 years, you're likely to become the patient who has preeclampsia or gestational diabetes if there's an underlying risk for diabetes. So unwanted pregnancies was also another thing, and that was brought about by economic hardship. A number of women who lost their jobs during the process needed to depend on men and relationships that they would not have otherwise entertained, or perhaps felt more empowered in those relationships, and decisions that were made. And I think another significant thing that really impacted was the loss of faith in doctors and healthcare overall, because of so many concerns around vaccines and the mixed messages. I think overall the healthcare industry did a very poor job in communicating, and there was so much misinformation. Individuals were home, Dr. Google did not help, so, we really, I think there's, that loss of faith in the healthcare industry and healthcare practitioners overall, that did untold damage. Individuals now becoming non-compliant. Individuals who were compliant to medication suddenly started distrusting doctors, and how that also factored. So, again, this is super interesting. And when you think of intersectionality, I always think of implicit bias, right? As a medical doctor, and when I see a patient, the sort of things that naturally come to mind based on how that individual looks, or the socioeconomic standard that you actually think of these individuals, you start thinking to yourself, in 5 to 10 years, some of the trends we will see, it really is worrisome. So again, thanks, Abby, for this wonderful work, and I don't want to to take up more of your time, but certainly interesting work, and I'm sure we can speak offline about this. Thanks.
Mr. Jeffers, any comments from you?
Okay, good day, everyone. The Department of Gender would have done a significant job during the COVID pandemic. During the pandemic, we would have seen increased calls from persons in distress, more so single mothers. The Department of Gender would have tried their best in assisting. We would have provided food vouchers for single mothers. For the elderly, we would have taken care packages to their home so that everybody could have had something to eat. And as much as possible, we tried to take the medication as well. So we actually took into consideration care for the elderly. Now, we also saw an increase in phone calls to the on-call counselors as well as to the field officers from the gender department. I must let you know that there is a department of counseling, the counseling unit located at Shadwell. They would have had an increased number of calls for persons who would have been distressed during the pandemic. The counseling unit, they provide counseling for persons, for single persons, as well as for family counseling going through the pandemic. And having spoken with the director for counseling, that was one of the concerns where the numbers were so high, and it was more so females who were calling, even though stress would have been on the behalf of both male and female. Since I have had taken the appointment of Director for Gender, which wasn't too long ago, I must say as the first male, I would have had my own stress meted out at me, because I had men who would have approached me asking if I'm here to advocate for them. Having indicated and given my utmost trust and best in working for the men, unfortunately, we are not really seeing the men coming forward. The men are the ones who tend to shy away from the services provided by the Department of Gender or from the social services or even from the counseling unit. And that is something I promise to have change. I promise to put a male face to the Department of Gender, and hopefully more men would be willing to come forward. Now, we would have also launched the National Gender Policy and Action Plan, and that takes into consideration as much as possible every gender, male, female, so that everybody could be accommodated for. It has just been launched. It was launched in June, so we are still doing the groundwork in terms of laying out the way forward. We would have invited key stakeholders within the community to be a part of the launch, and would have gotten feedback. We are yet to have the launch in Nevis so that they too can have their feedback as well. But Department of Gender, we also provide mentorship programs for males and females, and even for teen mothers. And these are some of the programs that we provide. We were also working closely with the Ministry of Health, because during the pandemic, we realized there would have been an increase in persons with the NCDs, and where possible, we would have made recommendation that the Ministry of Health would have given some urgency to persons recommended by the Department of Gender, so that they too can receive the assistance as quickly as possible. The Department of Gender, we also provided and still provides the financial assistance for persons who seek medical attention overseas. So if it is a need where you have to travel, as much as possible, having done due diligence checks, we provide you with the financial assistance where you may either have the surgery overseas or provide the assistance of having someone to accompany you while you travel and do your Medicaid overseas. The Department of Gender continue to work closely with the public, and we try our best to offer as much assistance as possible to ensure that everybody is happy and healthy. I think I too would like to say thank you to Abby for inviting me to this informative. I'm happy I accepted, because I'm happy to learn. I'm happy to share what is being done and learn from other persons as we continue to work hand in hand to make a better society. I want to say thank you, Abby. Thank you to all the stakeholders who would have assisted and participated with you, so that you could have had your research completed and you have the information to share with everybody. Thank you so much. Thank you, everyone.
So much, Mr. Jeffers. I think Fanta just had to step away for a while, so I'm just going to quickly take over as moderator. So does anybody have any questions at all for either myself, for either Dr. Doyin, for Dr. Pierre, for Mr. Jeffers. So does anybody have any questions? So whilst we wait for people to think of questions, I'm going to take my moderator privileges and ask Dr. Pierre a question. So Dr. Pierre, what is your feeling around doctors' ability to really try and address some of the gender-related issues that people with NCDs live with? So in terms of, because there's the easy gender issues. There is, okay, someone has prostate cancer and that's a man, and then someone has breast cancer and that's a woman. But there's some other issues that we, I guess, have raised around the issues of single mothers, older women. So how do you think that doctors are able to address those issues? And if not, what could be done to sort of help them in terms of capacity building to be able to address those gender issues?
Well, that's a great question. I think, first of all, it starts with research like yours, Abby. I just think that as doctors, sometimes we get so tunnel vision in terms of providing day-to-day care that we don't step on nearly enough. Well, that's one, to really look at things and zoom out and look at how all this plays into the care that we provide and the outcomes that we get or don't get sometimes. I think that's one of the things. The second thing is that the reality is that so much of that type of body of work like yours is lacking in our setting. We have a lot of things that, we try to extrapolate some of those things from the US or from the UK or from another region, but sometimes those social determinants of health are slightly different, right, in our setting. But what I do think we can already do, and I spoke about, that sort of unconscious bias, right, that we have. And often, unfortunately, that actually has more of a negative effect in terms of how we actually treat patients than a positive effect, right? So a lot of times we look at a young lady, for example, who comes to me with a repeated STI. My mind is that this is a promiscuous person, as opposed to what are some of the things that would have factored into that individual being in that position, and what can I do as a medical practitioner to help curb some of those behaviors and provide some type of support. But there's also the fact there's lacking in those social safety nets, right? I mean, so as a doctor, I say, if I take this on, suddenly I feel that I have to become burdened with this because there isn't a department that is reliable I can refer that person to, because you really need to have that sort of interconnectivity of all the different agencies, right, of government to really support that. And sometimes we as doctors, we either put our blinders on and try not to delve into this. We sometimes develop certain sort of unconscious biases around those things that help us to just sort of, because well, that person is making that decision, and therefore that is the outcome. We do what we can, which is the little patchwork that we can, right? But I think I really think this research, and I want to get more of the work that the last name is really difficult, but I see her smile. She has the most beautiful smile there. So, honestly, the work on interconnectivity, it is such an important, and not just, and a lot of people have spoken about the corporate world, and yes, and I face it every time. I'm the angry black male, right, when I speak, and I spend so much of my time self-editing. But I think it's really about how all of those things play into how we view our patients, and we really need to revisit that. And I think that's what we can and we should be doing right now as a start. And then, of course, as I said, tap into work like yours, and then see how we can build agencies around that really help to create that sort of multidisciplinary approach to healthcare.
Great, thank you so much, Dr. Pierre. So I'm going to put Doyin on the spot. So Doyin, based on what Dr. Pierre just said, what would an intersectional policy response look like? Like if we're to address some of these issues, like what would be your advice and guidance, both for the Department of Gender Affairs, but also for the Medical and Dental Association and the Ministry of Health?
Thanks, Abby. I will respond to that, but I also do want to, before I do that, would just want to just say a little bit more about the notion of unconscious bias, which I think is so important, that Dr. Pierce raised. So, I just want to amplify what we've heard so far. One is that we do carry with ourselves or into different situations our assumptions about what people's stories are. And yes, and thank you so much for your graciousness Dr. Pierce, for saying, you know, like you might see a young woman from a particular social background and make assumptions about how she has come to you with a particular kind of medical issue. And also it happens on the other side, i.e. we have our own, all of us carry our own biases around what surgeons should look like. You know, we might have particular expectations that surgeons are older people of a particular gender, you know, or, you know, older men rather than young women. And these biases influence the way in which we interact with each other and the degree to which we actually can provide the ideal service to each other. So I think it's just, all I wanted to do was say it is so important. It is so, so important. And I know, again, in terms of the healthcare data in the UK, that because of these unconscious biases, Black mothers are poorly served in maternity wards because of assumptions about how how much pain Black women can take. Right. So even these implicit assumptions that, oh, actually, you know, Black women can be strong, like feeds into the quality of healthcare. So I just want to amplify that and to say for all of us, to the degree that we can be aware of what our own biases are and how they can influence where, you know, our interactions. And then I do want to maybe just leave you with another final slide that essentially just speaks to the question that Abi asked in terms of what can we do from an intersectional policy perspective, from an intersectional thinking perspective. And, you know, there are many things or many potential actions, but I really just want to highlight two, which I think are relatively straightforward, which is whatever data you have, qualitative data, quantitative data, anything that you're using to inform your evidence-based policy development, your evidence-based recommendations, to the degree that you can, break it down intersectionally. Like, you know, if you, and for many of us, one of the struggles we have in the UK is that, you know, a lot of organizations are like, well, you know, I don't have that data. So for example, I don't have disability data. People are not self-identifying or disclosing their disability. They're not disclosing their sexual orientation, et cetera, et cetera. I'm like, okay, but what data do you have? Do you have gender? Yes. Do you have ethnicity? Yes. All right, use that, break it down. And when you break it down, whatever data you have, so disease, you know, the extent to which people have different disabilities, the extent to which you have a sense of what people's social status are. When you do that, use it to ask new questions. So broadly speaking, you know, what are the differences, or, you know, so for example, I'm just going to use an example, for example, right now in terms of people who have disabilities, men who have disabilities versus men who don't have disabilities, you know, just to kind of simplify it, say, to what extent is this solution I am offering, or to what extent is this pattern that I'm looking at different from men with disabilities versus men without disabilities? So just use that, and then that will surface more insights. And it might be that actually we don't know, or actually there's no difference, which is superb. And then in addition to working with your data, I would always say, to the degree that you can, even in terms of our everyday conversation, and, you know, Abi and to Lake Health, you know, kudos to you, because you're injecting intersectional thinking into these conversations around NCDs. And you're saying, you know what are the different lenses that we can put on it? All right, we've put gender, we've put age, we've put social economic status. So to the degree that all of us on this call can think about injecting intersectional thinking, when someone around you says, well, you know what, actually, the data suggests between, you know, again, just an example, between men and women, these are some of the findings. Great, ask, all right, what about different types of women? What about different types of men? So I just want to leave you with these initial ideas and practical suggestions for interjecting intersectionality into data and policy.
Thank you so much. I'm looking in the chat, and I see there was a comment about, you know, men opting to source home remedies for management of non-communicable diseases. And I'm wondering, Abby and Doyin, perhaps you can respond to this too. How do you think that culture and these sort of ingrained behaviors introduce opportunities, but also threaten our ability to truly assess intersectionality? And what suggestions do you have in sort of circumventing that? Because I think Bernadette's comment is a really good one. Perhaps women were reporting this more because women are socialized and acculturated to be more comfortable doing those things. Any thoughts?
Yeah. Abby, I'll jump in and then I'll pass over to you to add anything. Banta, this is the essence, i.e. the ways in which these identities or categories have been socially defined or socially constructed. And so, you know, for some people on this call, people who are experts in gender studies, some people on this call or people who listen to this later on may actually challenge us because some of our, we in many ways, you know, what it means to be a man, we define it like these things aren't real per se. Well, they are real in that we're the ones that say, well, you know what, men should be, you know, hardworking and should lead families and should be strong and therefore shouldn't have emotions. Like we are the one, society is the one that's playing and making that a problem. And therefore, we have things like toxic masculinity. We have things like low emotional intelligence. We have things like young boys who don't know, who don't have the opportunity to experience or express the wide range of human emotions. We have young girls who are not encouraged to be in leadership positions. We have young girls who are told to, you know, be kind and be sweet and all of those things rather than actually, you know, step into the glorious personality that they have. So culture and how we socialize everyone, socialize men and women, socialize people into masculine and feminine stereotypes has a lot to play in this. So I think, again, for us doing the research, so Abby and I were very careful around really trying to really understand that some of these, you know, quote unquote choices that people were making, they weren't choices, they were choices, so to speak, that society or the structure had put on them. It wasn't that they were choosing to do this. So I think when we think about policy recommendations and also, you know, when we think about research, when we think about change, let's also think about how we can challenge the assumptions that, for example, men, you know, that, you know, men shouldn't, you know, that this is the appropriate thing. We should think about actually, you know what, let's not disincentivize particular individuals such as men for being open and being vulnerable. Let us actually celebrate it. So those are some of my thoughts about that. Thank you, Banta. Abby.
Okay, great. Thank you. I'm actually just going to respond directly to what the person basically was saying about the herbal remedies. So to be honest, we saw that in the project. So men were more likely to want to seek, well, should I say more likely? We saw evidence of men wanting to use herbal remedies to manage their NCD condition. So in particular, there were men that basically were saying, okay, they don't really trust traditional, or should I say conventional medicine, i.e. the diabetic medication or the hypertensive medication. So they don't trust that. They're worried about the side effects. They're worried about the intention of the doctor who's given it to me. Do they really have my best interest at heart, or are they just trying to sell me something? So we had all of that coming from men. Men seem to be a little bit more wary. And so they were like, okay, well, I'd rather kind of drink some bush tea. And so I could think of one man in particular who was like, he had this nice, should I say nice, he had this interesting sort of routine of managing, using his diabetic medicine, yes, but also using herbal medication and then also using lifestyle. So he had created his own little kind of routine around his NCD management, which was disrupted during the pandemic. But anyway, so men definitely were more hesitant to take medication, and they did seem like they were more willing to accept taking herbal remedies. And I think maybe that's an area to look at, because then we need to think about what is safe for an NCD patient to take as a herbal medication. And as there, could we put together like a recommended list that could be helpful? I don't know. So there is that. I think as well, I think somebody mentioned that men usually don't talk about their emotions. And definitely, I mean, men were less likely to want to take part in this work. They didn't want to talk about their NCD. They saw a lot of men just straight out refused to participate. They didn't want to, and those that did even participate, they seemed less wanting to go into the detail, less wanting to discuss. And so therefore, I think it was hard to really understand maybe the male experience, while we probably got more of an understanding of the female experience. It was probably a little bit more hard to understand the male experience. We got there. I think we got there in terms of the sort of generalities. We sort of got there, but I think you're right. The lady that said, Ms. Felix, who said that men usually don't. So the data probably more benefits women because we're able to get more depth around the female experience of NCDs. But it was still very useful because the men that we did speak to, we were able to get a really good, some sense of their experience and why they were feeling hesitant to speak and why they were hesitant to reach out to their doctor and sort of those kind of issues. So thank you.
Great, thank you very much. I'm not seeing other questions come through in the chat just yet. I do see a hand raised by Dr. Pierre though.
Hi, Francis. It will be remiss of me as a male and doctor to not
Thank you
on this, and you know, and again, it's, you know, as a male, as the primary breadwinner in my own family, right? I look at some of this. Well, this one very startling data was the ratio of men to women who died during the COVID-19 pandemic, and the ratio is 184 males to every 100 females, right? So there's certainly that disparity, and the question is, how then, and it's both a question and a comment, because the question is then, when you look at these income disparities that exist within both genders, and you think that the majority of men who have died, and what that sort of economic impact has been to that family with that loss of income from that man, and more I keep speaking to my male patients, and I recognize that a lot of times it's more fear than bravado that actually drives that decision, right? It is that man saying, if I get sick, what happens to my family? It essentially drives that family into poverty, and it can do so overnight. I remember seeing a gentleman a couple of days ago with his blood pressure was 230 over 120, right? And you know, and I asked a friend to drive him to the hospital, and halfway he said, I need to stop to just, I felt I needed to puke. And he ran out the car and did not go to the hospital. The reason being that he felt that he would be admitted. If he's admitted, he's a daily paid worker, and if he misses a couple days of work, his mortgage is in jeopardy, right? So a lot of times it is actually fear of that loss of income. And as we look at this in terms of the economic disparities and how we actually strengthen families by reducing that gap in income to ensure that both you know, male and female can contribute almost equally from an economic standpoint to those families. So yes, there's the archetypal male of, you know, of, well, you need to be strong and whatever, but I think there's been a shift in that. But I think we haven't done nearly enough in terms of addressing the income gap, and a lot of men actually still shoulder responsibility, and illness for them is perhaps the biggest existential threat in terms of that income in the family. So I just thought I would just add that as well, and not in the defense of men, but yeah.
No, I mean, in a way it is in defense. I think that's really important that we are talking about very different groups of people, not just in terms of their sex organs, but in the way they're socialized and acculturated. And it also depends on where, you know, where they live and whether or not they have a family. So thank you for chiming in there. I don't see other questions, and we're coming up to the end of the hour. So just want to, before I pass it over to our panel, to thank everybody for last words. Thank you so much for this past couple of hours. Very, very informative, great questions, really great conversation. Abby, I believe from a housekeeping perspective, the video will be available to folks if they've registered. So that will be coming through in your emails eventually. And thank you for having me as your moderator. I learned so much. I was so excited about this talk. So really, really great conversations. And Abby, I'll pass it to you to say goodbye.
Wonderful, wonderful. Thank you so much. So really, I just want to say thank you to everybody that attended today. Really appreciate you taking the time out to be with us. So if you are interested in receiving the report, we actually have 2 reports. So we have the report, which is specifically focusing on the impact of COVID-19 on people living with NCDs. And then we also looked at the policymakers' perspective as well. And then we also have the digital framework. So if you're interested in receiving those, let me know and I'll make sure that you get those. But I'm thinking that we're probably going to email it to everyone that registered for this session. So you should get that as well. But keep in touch. We're going to try and do some more events around some of the findings from this project. Just thinking it through that we probably need to do a session specifically on the policymaker side, and then maybe a session on workplace and NCDs, because that came up and there was some interesting, I didn't cover it today, but there was some interesting insights around living with NCDs in the workplace, both before and during the pandemic. So it might be useful to have some sessions on that. So please do look out for that. But generally speaking, please keep in touch. Again, sorry, and let me just say proper thank you. So I would like to say thank you so much to Dr. Pierre for your contribution. Really do appreciate it. You're always a really good support, really supportive of the work that we've been doing, and we appreciate it so much. Thank you to Mr. Jeffers as well. Appreciate you taking the time out to be with us today. Really appreciated your insight, and also look forward to working with you in your new role. I hope that we can work together in terms of addressing some of these issues that have come up in our project, and really wish you all the best because you're new in your role. So just wish you all the best as the executive director. And of course, thank you so much, Doyin, really for your presentation today and all your insight, both professionally and personally. It means a lot for me to have you here today. So thank you so much. And thank you to everyone who's joined. I think that's it, but keep in touch. Our website, let me just quickly share my screen so that I can share with you guys how to keep in touch with us. So, great. So yeah, so we've got a website, lakehealthandwellbeing.com. You can email us if you have any additional questions about the information that was presented today. So info@lakehealthandwellbeing.com. And we're on Twitter, Instagram, and Facebook as well. So please do get in touch with us if you have any questions or comments. And just thank you so much, everyone. Enjoy the rest of your day. Thank you so much.